Good afternoon, good morning. It's an honor and a pleasure to be presenting in the EADV with the IPC. My talk today is about treating women with psoriasis. These are my disclosures. I'm an advisory board and speaker for all these companies. And I'm going to start by talking about psoriasis, which affects specifically, I'm going to talk about women today. I'm going to start by Queen Hatshepsut, which is our ancient Egyptian queen, and she's the oldest known psoriatic patient ever. And they thought that psoriasis is God's curse. We all know that psoriasis is both multifaceted and systemic, meaning we have different phases of psoriasis. As you all know, these are all psoriasis, whether palms and soles, plaque psoriasis, inverse psoriasis, but also psoriasis is a systemic disease, and we have to remember that. It's associated by IBD. As you can see, there is a high incidence of Crohn's and ulcerative colitis. Also, patients have higher liability and higher incidence to get cardiovascular disease, like diabetes, hypertension, and so forth. And also, metabolic syndrome is very common between psoriasis patients. In 30–40% of patients, we can get metabolic syndrome, and eventually it becomes fatal. And of course, other maybe areas that can be affected are like the eye. And of course, we have psoriatic arthritis, which is a very important aspect of our disease today. Psoriasis negatively impacts the quality of life of patients. It has a very negative psychological impact on all patients. And this really depends on a lot of things: severity of the disease, the location of the disease, age of onset of the disease, and most importantly, the gender. So today we're going to talk specifically about women and how psoriasis affects women worse than it does men. We all know that psoriasis has a bimodal age of onset. We have a first peak between the age of 15 and 39. The second peak is between 50 and 59. And in this case, women of reproductive age represent a significant patient group. Now, how does women of childbearing age, what am I supposed to think about that? First of all, I have to think that half of the pregnancies are unplanned, and the implications of therapeutic options must be considered for all women who are sexually active and have an intention to have a family. So I've got to be familiar with the clinical presentations during pregnancy and what options do I have to treat those women. This is a very nice review written by Alice Gottlieb about the clinical considerations for the management of psoriasis in women, which I encourage you all to read. We all know that the burden in women is worse than men. They are less happy, more stressed, more lonely, more stigmatized because they care so much about the way they look. And they reported a very high GLQI score than men, despite having a better PASI score. And of course, women with genital psoriasis experience much more sexual dysfunction than men. So, does it affect fertility? In actual fact, it doesn't, but they found that 22% lower likelihood of pregnancy has been reported among women with psoriasis compared to the overall population. Why is that? For several reasons. First of all, women with psoriasis voluntarily don't want to have children. They worry about the activity of the disease during pregnancy. They worry about treatment during pregnancy. There is reduced intimacy due to embarrassment. And sometimes if the women have arthritis, they are physically unable to have intercourse. What happens to psoriasis in pregnancy? Almost half of the patients improve, but in 24% we get worsening of the disease. And 21% the disease is usually stable. During pregnancy, the maternal immune response shifts from Th to Th2 response. Hence, this improves psoriasis during pregnancy. And also estrogen level, when they increase, they correlate directly with the shift to the Th2 and improvement of psoriasis. Also, the psoriasis comorbidities increase the risk of negative birth outcomes. So many papers have been published about how psoriasis affects pregnancy, how these patients are at increased risk of hypertension, giving birth to large for gestational age infants, And sometimes they found that some of the patients deliver cleft palate. So this was shown that low birth weight and large for gestational age children are more likely to get, they're more likely to get with psoriatic patients. Also preeclampsia and eclampsia, they were found to be common among psoriasis patients. Actually, we need more studies, but there is a growing body of evidence that pregnancies in women with psoriasis need very special monitoring. We also have the problem of pustular psoriasis in pregnancy. And we all know that this is a very serious disease and we have to treat it like an emergency. And we have to collaborate with our colleagues from obstetrics gynecology in order to treat patients with pustular psoriasis during their pregnancy. Especially when we have severe cases, and neonatologist has also to be part of the team treating those patients. How am I going to manage those patients in the childbearing age? I have to understand, even though it is not thought to affect fertility, there is a 22% lower likelihood of patients to get pregnant when they have psoriasis. And again, I have to remember that half of those pregnancies are unplanned, and most patients will discover their pregnancy between the age of 4 and 7. So they are already on treatment. Again, we have a lot of review articles discussing this, and we have to understand that this is the ordinary options that we have to treat our psoriasis patients. But in pregnancy, we have to be very careful with what we use during those months of pregnancy. Of course, we have to encourage our patients to do exercise, to have healthy diet, to stop smoking. But when we consider the topical treatment, we are allowed only to use topical steroids, moisturizers, and calcineurin inhibitors. And we have to use vitamin D with cautions during pregnancy. What about topical steroids? They were found to be safe. We use low potency of steroids, and we have to be very careful with the amount of surface area that we use the steroids during pregnancy. We have to, please do not use anthraline. Please do not use retinoids. They are category X and they have to be avoided during pregnancy. Phototherapy in pregnancy is safe, only broadband and narrowband. We do not use PUVA during pregnancy because phototherapy during pregnancy, the Soralen and UVA is contraindicated because they have a toxic effect on the fetus. What about the systemic therapy? We are allowed cyclosporin and tumor necrosis factor alpha inhibitors. We are not allowed to use methotrexate. It is teratogenic and it has to be discontinued 3 months before the patient plans to get pregnant. And in this case, if you have a woman with childbearing period, please avoid methotrexate and please avoid, as you all know, acetretin because retinoic acid causes embryopathies and spontaneous abortion. Cyclosporin is a safe drug that can be used during pregnancy, but we have to monitor the blood pressure because these patients have a higher rate of preeclampsia and diabetes who take cyclosporin. So be careful to monitor your patient very closely. Biologics, we all know that this is, again, so many consensus papers that have been published about which TNF alpha inhibitors are allowed during pregnancy. And finally, we now have a certain drug that is allowed during pregnancy. From these data, we favor more TNF alpha inhibitors because they have more studies. Pregnancy outcomes are generally poor in patients with severe psoriasis. So I have to be very careful with what I use. So even if I have patients who are already on biologics, anti-TNF are allowed, but I have to be very careful that those patients, when they have a baby, it is not allowed to take live vaccines after 6 months after delivery, like the MMR vaccine, for example. Now, I have more long-term data on the anti-TNFs. They should be considered over interleukin 12 and 23, interleukin 17. Certolizumab can be used all throughout the pregnancy. And this is the drug that is allowed and FDA approved in order to use during the pregnancy. They have been the longest on the market, and within this group, this certolizumab pegol seems to be the safest choice, as its molecular structure does not cross the placental barrier. So now at least we can have a drug that can help our patients during pregnancy. And these are all data from the registries from different areas in the world that show how the experience with the use of anti-TNF inhibitors. So this is a useful option during pregnancy because there are very limited options available with our patients, and because it has a unique structure without the Fc portion, so it does not cross the placental barrier, and they did not find any harm that can come to the fetus. So this is labeled for use in the pregnancy and lactation by the FDA. So now these are practical points when you're facing women with a biologic contemplating psoriasis. First of all, the structure of the biologic and its likelihood of passage across the placenta has to be considered. The other thing, that now that we know that we have women who are planning on having a baby, they should plan a pregnancy when they are in remission, they're off medication, and to have the best fetal safety profile. Sometimes the situation is unrealistic, but at least I've got certolizumab pegol. It's positioning itself as the most likely safe option, considering absent or minimal placental transfer of the drug. And these recent findings regarding certolizumab pegol can fulfill an unmet need of a systemic drug to use in fertile age women with psoriasis without concern about fetal adverse outcome. And at the end, I would like to thank you very much.